All right, it's Thursday. You know what that means. So what we're going to do is we're going to go over actually 6 studies today. These studies, you see 2 up here, a lot of them are going to be in consensus. 4 of them are going to be in consensus, mainly because I wanted to make sure this video was shorter. And so I want to show you how I kind of incorporate that to get snapshots. And we can go through the other 4 papers in a snapshot format to kind of give you the bare bones, what is needed to know about them to be relevant to you. So this first one, it doesn't look like too much. Well, what does it mean? Dynamic instability is underestimated on standing flexion extension films when compared with prone CT. What does that mean? It means that the position, as well as with gravity, against gravity, loaded, unloaded, all of these things play a factor in what shows up on your image, whether it's X-ray image, MRI image, CT scan, etc. So even if the traditional method works for a lot of conditions and a lot of people, there are special considerations for pathologies and certain individuals' anatomy that may make us order a specific image in a different way to give us a more accurate result. Now, why is that important? Well, 2 main reasons. The first is because these images are only ever a snapshot in time about how well your body is underneath. Like, we lift the hood for a brief moment in time. There's only a few imaging studies where we don't do that, or where we get more movement info, and those are more dynamic X-ray image series where you can actually get snapshots as somebody bends forward, bends back, and you can kind of measure these different things. It's cool, but it's increased radiation costs, etc. So when we are considering certain pathologies, maybe we put you through the routine process. Maybe we send you out for an image and it comes back clean, but you have symptoms that say, well, hold up a minute, this doesn't necessarily make sense. Something isn't jiving here. Maybe then we would consider taking that same image in a different position that may be more accurate for the condition we're thinking now it may be. And we may either then rule something in that may have gone undetected, leading to years of, well, let's not even think about it, just years of no good. Or we definitely ruled something out because we took 2 cracks at it and it's like, yeah, no, we did it the normal way. We thought it still could be this condition, so we took it another way and it is still clean, which means it is most likely not that thing. It is still fantastic bits of info. The second reason that it's important to consider these things is not just because it's a snapshot in time, but I remember hearing going through school, I think we were taking and discussing radiographs of the knee, X-rays of the knee, and something like a 2 to 5 degree difference. So like, I can't even scale that for you here. Like, take a protractor and see how close, like 2 to 5 degrees differences in that thing. And it's like, that can completely change the verbiage on the report to say, oh yeah, bone on bone or adequate joint space. So it's one of those things where imaging is extraordinarily powerful so long as it's interpreted with nuance, and it's not necessarily, I mean, outside of like spying a tumor where it's just this big thing on the screen, it's like, aha, it has to be read and diagnosed by a professional who understands that there's variance, nuance, and likelihood ratios baked into just reading that X-ray study, where it's not necessarily absolutely inconclusive. It is, hey, that's great data. Now what do we do with it? So it's also why I'm not a fan of just blanket anybody coming into my office. You get an image, you get an image, you get an image. These things have to be warranted because there's a lot to consider when we actually get said image. Now, look, if we think, hey, yeah, I did something stupid, I was drinking and playing with construction equipment, okay, we can look for a fracture, no problem. But if it's a little bit more subtle, then very oftentimes I'm communicating with radiologists to figure out, hey, even before I send the order in, what should the study, the imaging study be? Like, what is the best gold standard? I keep an eye out for what is kind of on the market for, rotator cuffs are showing fantastic, accurate results with diagnostic ultrasound. They're looking at other areas of the body that can have more direct access imaging studies without specialty equipment. So not the big costly MRIs, which again, we have access to some that are actually really, really competitively priced. But like, hey, diagnostic ultrasound, it's usually inexpensive. It's great for diagnosing X, Y, and Z. Is this patient a candidate for that based on what I think is going on? Yes, no, based on the radiologist. And then we converse, and the same thing with the actual report. If it comes back where either it's clean, but I got a few questions, I'll call the radiologist. If there's something there where the verbiage, because everybody, believe it or not, even if it's medical language, it doesn't always, even sometimes the way that it's structured doesn't always make sense. So I'll double check with the radiologist. It's like, hey, what did you mean here? What does it matter? What should I be considering in my follow-up? But that's why I'm not a proponent of just blanket statement. Everybody needs an image because we don't know, blah, 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 blah. It's like we can do a fair job of screening who should be assessed. And then based upon what we think, maybe it's simple and routine. We don't need to consider anything special. Send them in. Maybe it's one of those things where there's some special hardware, like, hey, I've got metal. All right, no MRI. We got to work around that. Or there's a condition that we want to really make sure we rule in or rule out, and that may actually differentiate if you get a CT or an MRI, even if it's, you know, overlapping tissue, because it's like, oh, MRI, soft tissue, CT, harder tissue. It's like, well, not always, because some do much better than others for certain conditions, which is always why I'm for collaborative care. I am not above calling radiologists like, you don't know everything. Like, good Lord, if I gave you that impression, I did a terrible job communicating that. And I'm sorry, I really, really don't. I really need a lot of people in my pocket, in my team, to even look halfway, you know, like making it look like I know what I'm doing here. But before I get into a self-depreciating stand-up comedy skit on this thing, let's go to the next study. The effect of paraspinal muscle morphology on the development of osteoporotic lumbar vertebral fractures. Now, this one was a bit dense and a little confusing. It looks like it was out of, I'm going to guess, Russia or maybe Romania. But they basically made the conclusion, and it's kind of buried here, they thought that the study showed that the functional muscle mass of the paraspinal muscles is significantly lower in patients with osteoporotic vertebral compression fractures as compared to those without fractures. So that could mean one of two things, maybe one of three. One, maybe they had lower muscle mass before they developed the compression fracture, which means they had less compensatory mechanisms to distribute whatever load went through their spine, and boom, you have a break. Now, something to keep in mind, these people, all of them, the control group and the compression fracture group, had osteoporosis. So they were having a reduced bone mineral density to begin with. So they already had a very much higher risk of developing a fracture. So maybe that's one of those things, the final straw on the camel's back, where, yeah, you don't have the bone density. Now you don't have the muscle mass to distribute that load. And what structure is going to take that hit next? It's going to be the bone, and it collapsed. The second thing could be, as discussed, because this is a retrospective study, and the details are a bit fuzzy on this one. It could also mean that those who had a compression fracture, their rebound with trying to develop more muscle mass, you actually had muscle atrophy, or you didn't have as good of muscle mass post compression fracture recovery that you'd want or would expect. So there would be something about, you have a compression fracture, the muscles atrophy, and that's something that we need to keep an eye out for and build up over time. Either way, both ends really just kind of make sense in my mind. And even if it's one of those, the study itself didn't translate over that well as far as its results, then just the fact that they found the connection, no matter which version it was, like compression fracture must rehab to develop more muscle strength after compression fracture, or they didn't have a lot of muscle quality before fracture, well, then either way, anybody who's at risk of developing osteoporosis, well, frankly, most people in America, because we are at a movement crisis, and a lot of our health issues stem from basically lifestyle factors, because we have a ton of chronic diseases that we need to improve our overall dietary quality and movement quality. So this is just adding in an excuse in my mindset about why we need to be prescriptive in actually giving people excuses to move. So it's not like, oh, move because it's kind of good for blah, blah. No, no, no. We find that, this is another thing. If we don't have great quality of, tissue, when we can develop that quality of tissue, you're at greater risk of fracture. Well, that's not what the study is saying. It's afterward, we're like, fine. If you're not listening to what I say and being healthy beforehand and you develop a compression fracture, we need to rehab you anyway. You're not getting around the fact that we need to alter our lifestyles accordingly. Now, let me switch this Google thing so I'm not staring at myself. I'm using Consensus. So what you're seeing is essentially if an AI algorithm married PubMed, and it helps really show, because I can ask the paper specifically, like use the AI tool through the actual PDF to get specific questions out of it, which I've done before. Just like, hey, this odds ratio, what is it really trying to say? Because based on what it reads, it doesn't make sense. It's dense, and it'll help me understand some things, because I'm not a researcher. Like, it's a specific particular skill set that has its own language based on statistics, which I don't want to have to learn to the degree that you essentially need to sometimes to understand some of these denser studies. But we've got 4 studies on the docket that we've got little snippets that I'm just going to talk through. So this first one was talking about, the title was Differences in Lumbar Pelvic Rhythm Between Sedentary Office Workers with and Without Low Back Pain. So both groups were sedentary, and it tried to assess, were there differences in how the body essentially went through a movement process to do certain tasks, and did that correlate with low back pain? And so when we go through Consensus, what it does is you have four study attributes of the 7 that it goes through. It's like, all right, of the 7 that it likes to look for, it could not extract 3, like sample size, duration, location, but it could figure out population, what methods were used, the outcomes, the results, and a little 1 to 2 sentence summary at the top. So let's read the summary. Sedentary office workers with low back pain may have altered rhythm due to increased hip flexion muscle strength. So essentially a quote unquote imbalance, and I'm using air quotes very particularly here, in muscle recruitment and muscle development patterns in these office workers may predispose them or be a potential mechanistic factor in why they are either developing or maintaining low back pain. So the outcome was, kind of like the summary said, hip flexion, muscle strength, extension, muscle strength, hip joint range of motion, lumbar proprioception, pain, and disability scores were the outcomes assessed, with the results being office workers with lower back pain showed greater lumbar flexion and lumbar hip angle differences during trunk flexion. So when they actually moved them through, they noted greater lumbar flexion and lumbar hip angle changes in the back pain group. So it's one of those things where it's not necessarily, oh, I have low back pain because my back is weak because I sit. Nope, that's not what this is saying. This is saying it's just a recruitment pattern where your brain and body is always going through a triage mechanism of what is most easy or efficient at that point in time. And to do a task, maybe the pattern that got you there, basically letting you do what you needed to do in the office, is the same thing that is keeping you there, ergo not getting you out of pain. So rather than trying to say, well, I need to put you through a whole gym routine and get you on 20, 30 weeks of an exercise program to do X, Y, and Z, or on the converse end, it's like, well, you only need to do 6 weeks of really basic, low level, low load stuff. It's like, no, we need to figure out what pattern isn't grooving and just find a way for your body to reestablish great communication between its resources, its actual structure, its frame. So if it's A plus B plus C equals pain, let's just change the equation. Let's not add more. Let's not take away. Let's have a conversation of, okay, you have pain. It seems like it's right now a communication issue more than anything else. There's not that much, how should I phrase this? Without extreme outstanding circumstances, there is little in the way of me to think that there is a purely mechanistic reason for you to be in pain. There seems to be a movement pattern communication thing going on right now that is likely playing a factor in keeping you in pain. And we need to figure out a way for you to regroove and just re-coordinate how you're doing certain tasks. So you don't need additional muscle. You don't need to get stronger. You just need to change the fancy word is like a movement enneagram, a pre-programmed way that your body chooses to do a movement. And we just tweak that. And very likely it's like pulling the one stick away from the dam that finally lets the waters break through, is kind of the analogy I like to picture in my brain. It's not this, we need to fix everything. We need to change everything about everything you're doing, make you fearful about bending over, fearful about squatting. It's just like, those are all probably fine. There's nothing physically wrong with doing those movements for you. It's just that when your body puts in that little USB with that software to do that task, there's just a little virus in there that says, oh yeah, this is also painful, by the way. And so your brain just keeps playing that same software over and over. And we just go in there and we just try and clean it up. It's like, all right, let's just do a little sweep, clean things up. You don't need more coding, more software. You don't need less. We just need to clear up your brain, tying that movement with the virus of pain, and we can get you out of it. So I can rant quite a bit with different analogies, metaphors, because this is a very confusing topic that at any given point in time, somebody can clip this and then misinterpret what my intended point is. And that's oftentimes what you see on social media all the time, which I hate. So that's why I like to beat the dead horse and just go over it again and again and again and again. And it's also a big reason, or a big part of my practice, is just trying to figure out what way does this communicate, stick with the patient, ergo without giving them a fear of doing anything. So I'm basically trying to establish what is the best way to communicate with this patient at that time about what I know about their condition, where it is safe to do X, Y, and Z. Maybe we just temporarily, if it's inflammatory and just angry and acute, we just avoid a few things temporarily, but you shouldn't be scared, and we shouldn't try and develop a fear to do the tasks that we are actually trying to build you towards. But like I said, I'm getting preachy. We've got this one plus 2 more studies to go through. So I already put you through the snapshots. Let's go a little bit quicker. Obesity and systemic inflammation disrupt the compensatory role of physical activity in chronic pain conditions. So first up, the summary. Vigorous physical activity has a protective association with chronic pain. And when I looked briefly at the study, because I still skim everything. I still go through the entire study before uploading it to make sure that I don't completely rely on just the software. The chronic pain was, I believe every metric they measured was like migraines, general chronic pain syndromes, but it wasn't based on the studies completely protective from joint pain, because you got to think, if you are doing a vigorous level of physical activity, patients are going to report that they are feeling joint pain, even if it's not necessarily degenerative bad. It's just associated with the physical activity itself. So to me, it's still not a net negative. It's just showing that it's not completely protective from chronic joint pain. But this beneficial association is attenuated or stalled out in individuals with obesity and high systemic inflammation. What do I want to say about this? A lot of the times, especially when we're dealing with somebody who has these more metabolic issues, who we want to, no, let's back up. Let's say it this way. There was a point in time in my life where I was particularly unhealthy, physically, metabolically, the whole shebang. A lot heavier, basically I'm in the obese category. And if you measured my blood work, I probably had a high C-reactive protein, a biomarker for inflammation. And when you're like that, you get in the mindset of life's not fair. It's just my metabolism. It's genetics. It's blah, 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 blah. You know, I try something for a couple of months. I try the exercise. I try the diet. It's just not working. And a lot of that is because the first few steps, the first few dedicated things you do to get yourself healthier are some of the slowest and hardest for several reasons: the mental reasons, the developing discipline, the desire. We could get into the discussion of dopamine. We could talk about just lifestyle changes in general are not the easiest, on top of the fact that, yeah, the part of the weight loss for a lot of people, it starts off quick, but then it plateaus quick. I'm going to take that and put it aside for now. A lot of the rest of this takes time for your body to adapt to trying to get healthier. And so when you take somebody and you see a study like, oh, high level of vigorous activity is protective for most pain, and you just try and have somebody who is not healthy enough for the body to build and protect itself from future high intensity workouts, you're going to break them down a bit more. They may look at it as that's just unfair. Somebody who is, healthy, metabolically, relatively fit is going to get a lot more gains out of these things. Like we see here, vigorous physical activity is protective for people who are already healthy, or reasonably healthy, or not unhealthy. And so looking at that, somebody it's like, well, I'm overweight and all this, and I'm not going to do vigorous physical activity then. It's like, well, not yet. I want to get you there to enjoy those benefits, but there's several things that we need to clean up first and look at you as a whole person and put our timelines not at 3 and 6 months, but in the 2, 5, and 10-year range. So just because it is not protective yet, and just because we have more to work through right now, does not mean that we need to write this off and that we need to have you blaming blaming the world or getting into a very terrible mindset or blaming your metabolism. Because there's been several things out there where when you actually measure metabolism, it's almost never your metabolism. Like, oh, I have a slow metabolism. It's almost never that, genuinely. Even in people who have hypothyroidism, there are rough calculations that show your metabolism only slows in the most severe of cases upwards of like 25%, which means if I'm adjusting calories, I'm basically at most only adjusting somebody with significant hypothyroidism off of their body weight metric norms by like 25%, So it is very, very difficult, and I'm speaking from personal experience, to take those first few steps, to see those first few results, because these things take time and your body is trying to get healthy overall. And that is true. Your body is changing and it's going to be reducing a lot of the sources of those chronic high systemic inflammations. It's going to be trying to combat the myriad of things that happen in your body when you have obesity. Obesity is not, we really shouldn't think of obesity as mechanical. Oh, it's just added weight to the joints and that's why I'm in more pain. No, that is almost the furthest reason from the truth about why obesity is not something we want. It is entirely systemic, metabolic, and chemical. It is affecting your body. If there's any reason mechanically it's affecting your body, it's usually through a chemical source, like the systemic inflammation, the insulin resistance, all of the things associated with diabetes that are wreaking havoc on your body are what's causing the actual mechanical issues itself, not just the fact that you have more weight on your body. Your body is very robust in actually distributing that and being able to use its muscles to combat the mechanical side of things, but not the chemical. And if it's using a bunch of these chemical resources, systemic resources to put out all of these internal fires, it's no wonder that if we try and add vigorous physical activity on top of that, that it's not going to be protective yet. So for somebody who is obese or has that high systemic inflammation, we need to address that and keep you moving to a tolerable level. Like, we still need to hit activity guidelines. Maybe I'm not having you do a Hyrox or a HIIT or a high intensity interval training just yet, even though it's the shortest amount of time, it's the most benefit, blah, blah, blah. Well, no, we're not gonna have you do it yet, but you know what? Get a couple of additional walks in a day. We're gonna rely on NEAT, non-exercise attenuated thermogenesis, to actually get some of that fat burning. And we're also going to do resistance training a minimum of twice a week If you're really short on time, instead of HIIT, we're going to do circuit. Like, we're just going to make sure that we can adapt this to you to get the benefits you need, put out our long-term goals in the 5 to 10 year mark, and then we break out into looking at what should this year look like for you. Because people are just like, oh, summer's in, let's say it's a deep winter. Summer's in 6 months here. I think I can do it. It's like, well, yeah, but in the 6 month mark, trying to hit that goal is going to be miserable. I should know. So is it possible? I have to be, on record here. Technically, for a lot of people, getting into a beach bod is possible in a shorter time frame, but it is highly improbable. The process sucks. And I would much rather look at this as a sustainable thing that we can do for the rest of your life than just a burnout goal that we're going to try and get in 6 months. You're not happy, and then we put everything on after the summer. So we really have to take a look at the whole person and over typically a longer period of time, which is a perfect segue into this study. All right, not going to be as ranty on this one. So this was a population-based study in Korea. So Korean adults with low back pain. It was retrospective, so looking back at it, it looked at low back pain recurrence rates, episode duration, frequency, healthcare utilization, etc. The result was about 80%, which is what we also have other studies that show about that same number, experienced recurrent low back pain. And here's the kicker: with episodes becoming more frequent and longer over time. Well, why is that important? Well, even the study called for this. Based upon the fact that they became more frequent and longer over time, they increased healthcare costs, healthcare load, etc. So they basically said low back pain recurrence rates increased over time, requiring early intensive management and long-term follow-up strategies to mitigate the growing burden on individuals and the healthcare system. That's where places like my office come in. We need to develop integrative and collaborative healthcare systems that can manage these patients adequately, appropriately, and with the care they deserve, which means if you're dealing with an issue, hey, we know that this has a huge incidence recurrence rate, and that unless it's addressed, it doesn't always get better over time and over the person's life. So let's get in early, see somebody like myself, an evidence-based practitioner, to help you through the early stages and set up long-term strategies. I will talk to you about lifestyle. I will talk to you about things that will mitigate your risk, that get you through episodes, to really make sure that we can maximize what we're doing in life. And I'm not somebody who's like, well, yeah, see me weekly, or even see me bi-weekly, or twice a month. It's like, no, we usually have a discussion about what's in the patient's best interest. And yeah, treat me like any other healthcare professional. I mean, dentistry's got a great little maintenance routine. See them at least twice a year. Make sure your teeth are healthy. I can't see an argument for not advocating something similar. See me at least a handful of times a year, 2, 3, 4. And if you're particularly active or you have a particularly nasty case, we can have that individual discussion. Like maybe you're a blue collar worker with a bunch of comorbid conditions who's trying to stay on the job. Okay, maybe you're going to see me more for just to help you stay on the job, but I'm not going to make that blanket recommendation to the population. My blanket recommendation is treat me like other healthcare professionals that see you on, I would probably say, a quarterly basis is a pretty safe mark. But even that is for the people that have these chronic recurrent low back pains. That isn't everybody in the nation. Find a chiropractor, find somebody, see them quarterly. It's like, no. What we have evidence for is those people that have this condition, so low back pain, because its recurrence rates are so high, then you can see somebody. And especially when I'm talking about that, see me quarterly, yeah, harder recommendation for people who have recurrent low back pain, a bit softer, but still a gentle recommendation for somebody's like, well, I kind of want to be proactive and just get a little tune-up checkup. I'm also fine with that too, but nothing where it's like, well, I have wrist pain. Okay. You're in that gentle recommendation to see me quarterly, because I like to make sure that we can track trends over time and that a big health condition doesn't just pop up out of the blue. It's not just joint pain that I'm making that recommendation for. But again, I'm getting preachy. Something about this Thursday. I'm preachy. Last one, body mass index and the risk of a spondylolisthesis. So this is where part of your spine, where I like to call it Lincoln logging together, that joint is disrupted, sometimes traumatically, where there's an actual fracture. Sometimes they don't completely grow together. There's a lot of reasons for that joint to be disrupted, which would allow for the actual vertebra. And when people say, well, my spine is slipped, my disc is slipped, it's like, then I'm calling it a condition called spondylolisthesis. You know, it may feel like that, but unless I have it confirmed on an x-ray and you have spondy, I'm not going to say that. So a spondy is where it can actually slip, you know, forward or back, and depending on which one we're referencing, that's either a forward slippage, a backward slippage, and sometimes there's a little bit off to one side. Radiologists will use antero if it's slipped forward, retro if it's slipped back, lateral if it's slipped to the side in any degree, and then they measure that to see how bad it is. So what they found was elevated BMI significantly contributed to the risk of developing a lumbar spondylolisthesis, emphasizing the importance of weight management as a preventative strategy for spinal health. Well, how much more of a risk? According to the odds ratio, 1.66, we usually think of 1.0 as equal to, you know, just 100%. So an additional 66% on top roughly equates to you have a 66% increased incidence of developing a spondylolisthesis in your population. So if everything else is, you know, age, sex, athletics matched, if you are higher BMI, you have a higher rate, roughly a 66% increased incidence report of having a spondylolisthesis, which, depending on the mechanism involved, you know, a lot of the times we see what's called an idiopathic spondylolisthesis, where athletes typically who have a proclivity for a lot of higher stresses through the lumbar spine, we typically associate that like, okay, we have somebody who's going through gymnastics, who's doing a lot of this bending, a lot of this impacting. They're going through, especially at a young age, because gymnastics is a particularly young sport, we're likely to see that during the development that the spine is maturing, that it can lead to these idiopathic spondies. But, you know, I've seen it in basketball players, football players. So if we're having somebody with low back pain, they're athletic, especially to me, in a younger population, who shouldn't have the level of back pain that they may report, I'll just say, hey, especially if they're, you know, in general, if they have the symptoms for it, but now if they're also overweight for their normalized age group, there's a higher chance that I'm going to see a spondy. Now, again, it's not guaranteed. Everything is like playing poker. You know, you see the odds ratios when somebody flips a card. It's like, oh, it went from 90-10 to 70-30. It's kind of the same way when we talk about diagnostics. Like, my odds ratios change, but that by no means means the deck is necessarily going to give me the card that we want to find. It may give us something completely random, and then we have to adjust accordingly. So control the BMI. There's lots of reasons for it. I discussed a few. Yeah, I think that's it. Well, if anything caught your attention, feel free to leave a comment, reach out to me personally. If anything I said, you know, stirred something up where it's like, wow, this sounds like I might want to have help. I might want to look at something. I want to have him in my corner to help me out. Reach out. You can go to my website, fill out a contact form, email me. We're here for you. We just want to make sure that you're living the best life that you possibly can. So until next week, bye-bye.